Hello, everyone, and welcome to today's webinar, Influenza, an Underestimated Threat. I am Marie Stone of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Thermo Fisher Scientific. To learn more, visit thermofisher.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Ari Frenkel, Chief Science Officer, Arkstone Medical Solutions. Dr. Frenkel, you may now begin your presentation.
Thank you for the introduction. It's an honor to be presenting today. Before we start, some disclosures, as you can see on this introduction slide. I want to also go into a little bit of my background to provide some context and objectives. We at Arkstone use Prescribe Responsibly as our banner in an effort to bring awareness to antibiotic overutilization and our fight against antimicrobial resistance. But one can only do this if our understanding of infectious diseases and how we treat these infections is optimal. My objective, as always, is to change the way people understand infectious disease so that we can use the best available evidence to treat these infections. I'm a board-certified infectious disease physician. I'm also board-certified in internal medicine. I've been in the infectious disease space pretty much my entire career. I sat in roles such as medical directors in many settings, including rural hospitals and large corporate settings managing multiple hospitals. I've dedicated my career to antimicrobial stewardship and changing the way healthcare providers prescribe antibiotics. As co-founder and chief science officer of Arkstone, we use technology and artificial intelligence to bring the tools healthcare providers need to understand infectious disease and participate in efficient and optimal antimicrobial stewardship. So let's jump right into it. In the last several years, COVID-19 has been the focus and forefront of public health, medicine in general, and infectious disease. What a lot of clinicians saw almost immediately was that other medical conditions were put on the wayside. Colleagues of mine noted that patients were avoiding care of other chronic conditions in fear of COVID-19. We also saw that COVID-19 was the focus of infectious disease testing, while many other respiratory pathogens were and still are capable of causing diseases, many of which present similarly to COVID-19. Many patients with viral upper respiratory symptoms would obtain COVID-19 testing, and when negative, workup was discontinued. With no underlying diagnosis and no additional testing for other pathogens that may be contagious or cause similar symptoms. Influenza is one of those pathogens that can present very similar to COVID-19 and can be overlooked if COVID-19 is the only microbe being tested for. When COVID-19 pandemic started, many people compared it to influenza, and they compared it to the impact influenza had in the pandemics influenza caused many years earlier. Many people are unaware of the history of influenza and that influenza was a significant and still remains a significant threat. In the last 100 years, influenza has resulted in 4 pandemics and several epidemics. The Spanish flu of 1918 to 1919, caused by H1N1, was responsible for 50 million deaths worldwide, including 675,000 deaths in the United States alone. Asian flu, caused by H2N2 in 1957, caused 1.1 million deaths worldwide and 116,000 deaths in the US alone. The Hong Kong flu, caused by H3N2, caused 1 million deaths worldwide and 100,000 deaths in the United States. And lastly, the swine flu, caused by H1N1, most recently in 2009, caused approximately 151,000 to 575,000 deaths in the world and 12,469 deaths in the United States. It doesn't take much to realize that influenza is a global threat. However, we can see in this graph that when we compare each pandemic caused by influenza, there was a dramatic decline in death toll across each one. 50 million deaths dropped to 1.1 million deaths, and approximately 39 years later, when the next pandemic arose, we saw that significant decrease. Only 11 years later, the next pandemic hit, and we also saw a slight decline in mortality. Lastly, in the most recent influenza pandemic, we saw 575,000 deaths, a significant decline in the death toll by approximately over 50%. We may be able to attribute the decline in mortality to modern medicine, vaccinations, and understanding of infection control and public health measures. The widespread exposure to influenza may have helped as well, as the majority of people have had either exposure to influenza or vaccinations, which may help with immunity and also lessen severity of disease and the spread of disease. However, it's important to note that even after 2009 influenza pandemic, we still see thousands of deaths yearly in the United States and worldwide caused by this influenza virus. In January 2011, the CDC estimated that the 2009 H1N1 caused illness in more than 60 million Americans, leading to more than 270,000 hospitalization and 12,500 deaths. Contrary to typical seasons, 90% of hospitalizations and deaths occurred in persons younger than age 65. So knowing how dangerous influenza is, where did it all come from? Influenza is believed to exist for at least 1,500 years. Some say that Hippocrates described influenza in his works, although many argue that this was not the case. It wasn't until Richard Shope isolated the virus from infected pigs that influenza was actually confirmed. Prior to Richard Shope's discovery, many assumed that syndromes caused by influenza were caused by a bacteria called Bacillus influenzae. And this was what people initially thought the 1918 pandemic was a result of. However, as we know now, that was not the case, and researchers never isolated their suspected bacteria. There are many types of influenza viruses and many subtypes. Influenza A and influenza B are the most common types seen clinically, while influenza C is rarely reported. With the use of advanced molecular diagnostics, we do see influenza C occasionally, however. Animal to human transmission and human to animal transmission is an important element in understanding influenza. Humans can get H1N1 and H3N2, and animals can get these viruses as well, as seen with swine. Horses can get H3N8, dogs can get H3N2, and certain birds can get H5N1. It's important to note that even though many animals get infected with the same virus as humans, they are technically different strains of this virus. The CDC notes that influenza A virus that are typically endemic in one animal species can sometimes cause illness in another species. For example, until 1998, only H1N1 viruses circulated widely in the US pig population. However, in 1998, the H3N2 virus from humans were introduced into the pig population and caused widespread disease among pigs. More recently, the H5N1 virus from birds have caused sporadic infection in wild foxes in the US and in other countries. This is a quote by the CDC. But why is this important? The answer is viral reassortment. Viral reassortment is the takeaway point here. This is an evolutionary mechanism that emerges with interspecies transmission. Genes are shuffled, so to speak, between viruses producing new strains of the virus. So we don't just see this with influenza, but with many other viruses as well. This is a biological mechanism, an evolutionary mechanism. Examples of this are the following. In 1957 and 1968, pandemic viruses have been determined to be reassortment of the avian virus into human virus genetic background. The H5N1 virus circulating between 1997 and 2007 apparently arose from multiple reassortment events among avian influenza viruses. And the 2009 H1N1 influenza pandemic emerged as a result of triple reassortment between avian, human, and swine viruses. When discussing the epidemiology of influenza, it's important to take into consideration how the virus is transmitted, and that is mainly through person to person via large droplets. And as we noted, some interspecies transmission occurs as well. Again, influenza A is found in humans and animals, influenza B and C mainly in humans. Influenza is a seasonal virus and occurs more frequently in different parts of the year, depending on your location. October to April or May in the northern hemispheres, April to September in the southern hemispheres, and year-round in tropical climates. This virus may be contagious in adults 1 day before symptoms arise, and even contagious 6 to 7 days after symptoms begin. In children, the virus may be contagious 10 or more days after symptoms begin. Here we see a diagram of droplet precautions. This is different than airborne precautions. The distance large droplets can travel in the air is much less than airborne spread. Once the virus enters the respiratory tract, it attaches to respiratory cells, the trachea and the bronchi. When the virus replicates, these cells are destroyed and it results in the virus spreading and can lead to respiratory failure. Because the virus replicates in the respiratory tract, mucus, saliva, and respiratory secretions can carry the virus and spread it from person to person. The virus is typically contagious for 5 to 10 days, as noted before. The virus's clinical presentation can vary from mild, like cold-like symptoms, such as a runny nose, sore throat, headache, fevers, to GI illness, like vomiting and diarrhea, to even more serious diseases, such as pneumonia, respiratory failure, septic shock, myocarditis, and pericarditis. Other key points to note is the incubation period, which is 2 days, and the resolution of fevers, which typically occurs approximately 3 to 4 days into the infection. Most symptoms resolve by day 7, however. The most vulnerable population is patients over 65 years old. Superinfections, or infections that can occur after or with influenza, include Staph aureus, strep, and Haemophilus influenza. Testing for the flu is relatively simple these days. There are typically 2 modalities of testing: antigen testing and molecular testing. How specific or sensitive this test is a way to measure the testing's capabilities. When something is more sensitive, it means the test has the ability to correctly identify the patients with the disease. When a test is specific, it means that the test has the ability to correctly identify people without the disease. According to some studies, antigen testing is very specific, but lacks sensitivity, meaning it can fail to identify patients who are true positive. Stated differently, the antigen test can rule in a disease, but is poor at ruling out the disease, while molecular tests are good for both ruling out the disease and ruling in the disease. New technologies, such as Multiplex PCR, allows for testing of multiple viruses and other potential pathogens in a single test using a single sample. So if a patient has respiratory symptoms consistent with a wide range of pathogens, say, for example, influenza, RSV, COVID-19, and rhinovirus, a respiratory panel testing for multiple viruses simultaneously can aid in the diagnosis of this infection rapidly and accurately. This provides many advantages when compared to Singleplex PCR, which only detects a single microbe per sample. Management of influenza depends on the clinical scenario, with most antivirals having benefit within 48 hours of symptoms, however. We have many antivirals to choose from, each with pros and cons beyond the scope of this lecture. Tamiflu is the most commonly known antiviral for influenza. Zanamivir is also another antiviral. However, this one can't be given to children who are less than 8 years old or with a history of asthma or COPD. Baloxavir is a newer antiviral and apparently has greater reduction in viral shedding than Tamiflu. It's similar for influenza A, but superior for influenza B, according to some studies. There are some other antivirals, but only available in IV formulation. Of course, supportive care, such as symptomatic medications and oxygen if necessary, as well as hydration, should always be provided if needed. Antimicrobial stewardship is key, as antibiotics are not necessarily needed when treating flu. Unfortunately, we see that many respiratory infections are treated with antibiotics, despite the fact that the causes are viral and will not respond to antibiotics. COVID-19 has led to excessive antibiotic use and exacerbation of antibiotic resistance. With that being said, there are scenarios where superinfections do occur, especially when patients improve initially and then deteriorate afterwards. Common causes are strep and staph, as noted earlier. Prevention of influenza is key to stopping transmission of the virus and reducing the intensity of disease. There are many types of vaccines available, including inactivated, live attenuated, and recombinant. Like the treatment of influenza, each of these vaccines have different advantages. However, all people greater than 6 months of age should receive the influenza vaccine with minimal exceptions. As we discussed earlier, due to antigenic drift, immunity is typically less than a year, with efficacy of the vaccine at 40 to 60% at times, although very variable. Vaccinations of influenza have led to fewer deaths among children and fewer complications in general. Other important modalities of preventing influenza is post-exposure prophylaxis, which is when an individual who may have been exposed to influenza receives antivirals soon after in order to prevent disease progression and possible transmission to others. Contraindications to vaccines include any type of allergies to vaccine component, although typically rare. There is a lot of confusion as how vaccines work, and this can be a lecture unto itself. However, generally speaking, the vaccine stimulates the body's immune system so that when an actual infection occurs, the immune system is ready and prepared to neutralize and reduce the spread of infection, subsequently reducing the risk of transmission. The influenza vaccine is safe, and millions of Americans around the world receive this vaccine for over 50 years. The benefits outweigh the risks, and the side effects of the vaccine have been evaluated extensively and rigorously in many studies. Unfortunately, a recent study has shown that only 50% of Medicare recipients had claims for influenza vaccines, meaning half the patients did not receive a vaccine for influenza. My final takeaway points and objectives of this lecture is that influenza is very dangerous and can often be overlooked, especially within the setting of COVID-19. Influenza has caused millions of deaths in the last 100 years. It has led to multiple pandemics and has the potential to lead to even more pandemics in the future. We have the ability to rule out influenza along with other dangerous viruses using advanced technology and testing. With advances in medicine, we also have many treatment options should one get influenza. But most importantly, vaccines still remain the primary method to prevent severe illness and the spread of disease. I want to thank everybody for their time, and I would like to address any questions anybody may have. Thank you.
Thank you, Dr. Frenkel, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, what are H and N in H1N1?
Sure. I hope everybody can hear me okay.
Yes.
So the H and the N stand for proteins found on the virus. H is hemagglutinin, N is neuraminidase. And again, it's a little bit beyond the scope of the lecture, but those are proteins found on the outer shell of the virus. And different viruses are known to have different proteins. There are about 16 hemagglutinins and approximately 9 neuramidases. And the way we classify influenza is by the combination of those different proteins. So we got approximately 144 give and take combinations that we can make out of those different proteins. And so that's how the influenza virus is labeled. There are different types of labels that the CDC provides for influenza as well. So it's not the only way that we classify influenza.
Right, thank you. Next question. Can SARS-CoV-2 virus alpha, beta, gamma, delta, epsilon, and omicron variants cross-speciate with influenza A, B, and C? If so, what are current evidences?
That I don't believe so. As far as I know, currently, I don't believe that's the case where we can see two different types of viruses, not within the same family, create some sort of cross, or like we mentioned on the lecture. I don't believe that's the case that it can happen. It's usually within the same virus itself. But But and I don't know of any data that suggests COVID-19 has that potential.
All right, thank you. Next question. How can multiplex PCR assist labs during the upcoming flu season with COVID-19 still here?
So it's a good question. So the way you have to see it is that when you have a viral syndrome, when a patient comes in sick with your classic viral syndromes, fevers, coughing, runny nose, headache, fevers, it's very hard to know exactly what that is. And traditionally, a lot of physicians would say, well, the patient has a virus and it will take its course. But because of new technology, we have the ability to actually diagnose these viruses using molecular diagnostics that uses the virus's DNA or RNA to identify it. And multiplex, as noted in the lecture, gives you the ability to test for multiple pathogens simultaneously. So if you're looking for a patient who has general viral symptoms, you could run a series of tests on them in one shot, in one sample, and hopefully get to your diagnosis. So if you're suspecting that a patient may have COVID-19, but it could also be influenza, it can also be rhinovirus, a respiratory panel may help differentiate that. This way, nothing goes undiagnosed.
Great, thank you. Next question. Can a recent COVID-19 infection protect against influenza?
I don't believe that's the case. Usually, we will get immunity from viruses either through vaccinations that are specifically designed for that virus or by being exposed to that virus, and natural immunity occurs. But cross immunity, to my knowledge, will not happen between influenza and COVID-19. And that was one of the reasons why COVID-19, when the pandemic started, was a significant issue because we didn't have anything available to protect people. If the flu would provide protection, then theoretically we may have been able to use the flu vaccine as a form of vaccine, but there was no cross protection on that. We sometimes see cross protection, like we will see with smallpox and cowpox. That was famous cross protection we saw with that, and sometimes we do see that, but not with these two viruses.
All right, thank you. Next question. For detection of flu A or B, RT-PCR, how many genes should be targeted for each to be sure that we detect it correctly?
That's a good question. I'm not exactly sure of the answer of what exactly on the molecular side they're testing for. When it comes to COVID-19, generally speaking, they're looking for 2 or 3 genes to consider that a positive. For flu, I'm not sure exactly what on the lab side they're doing. So I would have to defer that question to somebody who may know that part of the diagnostics better than me.
All right, thank you. Next question. As the influenza vaccine is now advised to be administered at the start of the flu season, is there an aggressive plan to educate individuals worldwide that they should not wait to get vaccinated each year? I know this is a common reason many Americans hold off on getting their flu vaccination. Many others are also certain they've become sick from the vaccine, not considering that maybe they had already been exposed to someone with the flu.
I think it's always a challenge, especially from the public health side of the equation, as far as educating people on vaccines and the benefits. Right now, the recommendation is yearly vaccinations for influenza, and that hasn't changed. Because influenza changes from year to year, and because there's variations in the virus, that may affect how well the vaccine is received and how well we have and how protected we are with the vaccine. But that shouldn't deter people from getting the vaccine because all the data shows that that it's of a benefit, and a little protection sometimes is better than no protection. And we do see that data shows that there's clinical improvement and better outcomes on those who are vaccinated. So we always see a positive outcome on vaccinations. So nobody should wait. And if you're able to get the vaccine, that's what we should do.
All right. Next question. What is meant by an attenuated vaccine?
So attenuated refers to a weakened virus. There's many different ways that vaccines can be prepared. Most recently, we have heard of the mRNA vaccines, which is the latest technology that we use for COVID. But sometimes, and again, going back, the objective of a vaccine is to almost trick your body's immune system to thinking it's infected. So ways that we do that is introduce proteins of the virus. Sometimes we actually introduce the virus, but a weakened version of it. And that will basically have your body react to the virus as if you're being infected, which prepares your body to fight the true infection or real infection when it happens. So attenuated is a weakened version of the virus so that the virus can't actually cause the infection, but it's introduced so that your body thinks that it's being infected and can protect you from real infection in the future.
All right, thank you. Next question. How can we estimate future interactions between COVID-19 and influenza? Do we believe the dramatic drops in the 2020 and 2021 flu rates were associated more with COVID-19 NPIs or COVID-19 having an antagonistic effect?
So I think that the answer to that question will come as we get more data. Once we analyze what's been happening in the last couple of years, there's a lot of co-founding, I think, elements to this. When, as I noted in the lecture, we saw that there was a heavy focus on testing for COVID-19. So there could be some bias that people weren't being tested necessarily for influenza, and naturally that would shift our diagnostics and our numbers. We also know that people were taking extra precautions because of COVID-19 and the pandemic, wearing masks and isolation and shutdowns, and that could have also affected the spread of COVID-19 and influenza. But there was some concern, and there still is concern, as the impact of influenza causing severe illness and COVID-19, because now COVID-19 is a new player, so to speak, in our respiratory infection. So I think that we're still learning more about how they are going to interact together and how it's going to change basically our mortality when it comes to respiratory infections.
All right, thank you. Next question. Are the rate of mutations in the flu virus as the same as for the COVID virus?
Thankfully, no. Influenza is, I believe, and again, I'm not an expert in the microbiology of influenza, but I do believe influenza does have the propensity to shift or change more frequently than COVID-19. In fact, one of the concerns was when COVID-19 came out is how well will the vaccine work against COVID-19? Do we have to be concerned that it's going to be similar to COVID-19? Similar to influenza in the sense that the vaccine needs to change from year to year. So as we know now, COVID-19 has changed, and we do see different variants of COVID-19, but it's not to the extent that we see at this point that we've seen influenza, although this could change. Again, COVID-19 is evolving data, so that may change over time, and we have seen more variants of COVID-19 than I think we initially expected to see. So the answer, to sum it up, is I don't know yet whether or not that's the case.
All right, thank you. Next question. Do you know if there is a difference in terms of sensitivity and specificity of antigen testing from nasopharyngeal swabs versus bronchoalveolar lavage? Of course, when the material type collection is chosen according to the respiratory symptoms and the stage of infection.
That's a good question, and that's a difficult one to answer because it depends on the equipment that you're using and whether or not it's indicated for that. So we also saw this with COVID-19, whether or not we could take samples or oropharyngeal samples versus nasopharyngeal samples, and that depended on whether or not the equipment and the type of swab. So there's a lot of factors as to whether or not there could be something that can impede the detection. The reason why nasopharyngeal was the preferred is because of where you find concentrations or colonizations of the virus, and where you're most likely to get highest yield from it. But we do see that changing. So I don't know the answer to that question necessarily, as far as whether or not we'll see equal diagnostic abilities. But the testing and the molecular diagnostics is getting better and more sensitive. So I wouldn't be surprised if we can obtain the sample from really anywhere, and it would still be an accurate test.
All right, thank you. And we will wrap up with this last question. Are both influenza A and B shed in the GI tract?
Generally speaking, the virus is found in the respiratory tract, and it's transmitted through the droplets because, as we noted in the lecture, we'll see the virus shed in the and it would use the cells in the trachea and the bronchi. That's where it replicates. So that's where the virus is spread from, and that's generally where we check to see whether or not patients have the virus. That's where we're doing a respiratory sample to detect the virus. Whether we can detect the virus in the GI tract and in that's something that I have not seen people use that. I am not actually sure as far as the incidence of detecting the virus in the GI tract. It's a good question. I'm sure if a patient is vomiting, we may be able to detect virus in that fluid. Whether or not we'll detect it in the other areas of the GI tract, I'm just not sure. But anytime we do diagnostics, we want to go with the highest yield, and we want to go into the source of where we can get that. And for influenza, it's generally speaking, it's going to be the respiratory tract.
Great, thank you. And I've just been notified because we were getting so many great questions that we have time for two more, if you mind sticking with us. Um, so, do you anticipate seeing mRNA vaccine development for influenza viruses in the future?
I think so. And again, I don't have access to any more information than what the CDC provides or general information that I can find. But based on what we saw with the COVID-19 virus, how effective the vaccines were, how fast they were and to basically create, I think that mRNA vaccines will be the future of how we make vaccines. Let's talk about using the mRNA technology for a wide variety of different pathogens that in the past we may have not thought about exploring vaccinations for. So mRNA vaccinations open up a whole new world for vaccines. So I would expect that we will see this. It's just my suspicion. I could be wrong, but I think we will see this for influenza as well.
All right. And our last question, could mRNA vaccines be more effective in preventing influenza?
Good question. It's hard to say because again, when we give somebody a vaccine, our purpose is to introduce to the body a pseudo infection, a false sense that there's an infection happening. Ultimately, it's the body's reaction to that to build up immunity. So mRNA vaccinations achieve the same thing. Whether or not the immune response is going to be higher for an influenza vaccine through mRNA versus the traditional methods is yet to be seen because we would have to study that. We'd have to know and do a comparable study as to whether patients with the mRNA vaccines do better than those patients with traditional vaccines. So it's really hard to say at this point. And really, the COVID-19 was our first public approach with mRNA vaccination. So as we roll out that new technology, we may end up having the answer to that question.
All right. Thank you, Dr. Frenkel. Do you have any final comments for our audience?
No, just thank you very much for attending and on hearing what I had to say. I hope you learned something from the lecture, and I hope this helps spread awareness that there are many things to worry about, but we could tackle them. We've done a great job with influenza overall. If you see that slide where we saw how the change in the death toll from 1918 to 2009, how drastic that was. We've learned a lot from influenza. We've learned a lot from COVID-19. So hopefully we can take this information and we can use it so that the next round of pandemics, which are bound to happen, we approach it much differently.
All right. Well, thank you again, Dr. Frenkel, for your time today and your wonderful presentation.
You're welcome.
We would also like to thank LabRoots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.